So when we're looking at herniations, which I could have just continued that other one on, but I didn't. There are several types, and really I think it's not important that you know all those at your level. If you were going to be working in the unit, that'd be one thing if you learn them, but I think this is just fine if you just understand that. There's not much place for the swelling to go. So if we can understand that, what we want to know is we want to try to prevent herniation from happening. So that's the goal. The goal is to be on top of it with monitoring and vital signs and everything, and to keep this from happening if we can, because it's the shifting of the tissue and all is what the herniation is, and that it will shift downward and cut off vital functions. That's just the main thing. And if we are not able to intervene, or if our interventions don't work, then they will do a rapid downward spiral and die. So that's not a good thing. Okay? So of the syndromes, UNCAL is the one that's kind of the most often what we see, and this is where a shift of either one or both sides of the areas and the pressure increases, and it causes displacement. And here you can see what we get: ipsilateral, pupil dilatation. I mean, all brain herniations are potentially deadly, so they go quick. It's not a good thing. Cushing's triad, that's that widening pulse pressure and respirations and pulse down. Those are bad signs. They're late signs. They're too late to get much accomplished. Okay, so this is what we see. And I'm just going to go right into the coma and a persistent vegetative state. Okay. In a coma, the patient has no wakefulness. They're not aware of the present, nothing going on. It's not a disease, it's just kind of accumulation of things. It's a symptom. And it can be caused by a whole lot of stuff: brain tumors, abscesses, CPR that's had to be performed and was unsuccessful, poisoning, that's a real common one, drug overdoses. Oh my goodness, over like probably 30% of what they see in the ER of comas are caused by that. Trauma, cerebral hemorrhage, subdurals, thiamine deficiency. Okay, so we're always looking for that. Hypertensive encephalopathy, hypertension, sudden onset, what have you. So all of these can cause a lot of metabolic problems can cause these comas, and even some psychiatric disorders can cause them. Okay. Now, hold on. Oh, I've got this messed up. Hold on. Okay. We looked at that. Okay, so these are still some of the causes: hypoglycemia, hyperglycemia, hepatic coma, pneumonia, eclampsia, just a myriad of things that can happen to cause a coma. So how they will assess it, they're going to do a thorough examination. Obviously, the patient will not be the historian because they're in a coma, but either family or significant others. And by history, if they know what's been going on with the patient, what's comorbidities and all are going on, they may have a clue as to what's going on as well. But they'll also do a detailed neurological examination. They will do CT, MRI, to verify if there's anything going on, any tumors or what have you. LP, unless there's other signs that may contraindicate doing one, but they'll do lab studies to see what their levels are, drug testing, what have you. So trying to rule out anything to know what the cause is to see if they can treat it. Now, obviously, somebody rolls in the ER in a coma. We don't know what they're if they've had a bunch of opiates or what. So they'll probably give them Narcan to try to reverse that. That would be an okay thing to do. So what we want to do is find out what's going on so that we can treat it if it's a treatable kind of thing, which makes perfect sense, doesn't it? Okay. So we will do whatever we need to do to support vital functions. We'll put them on blood pressure medicines, ventilators, and what have you, because until we know, we don't want to just give up hope. So it depends on what it is, how long they've been unconscious, that kind of thing. So certainly the best prognosis is associated with early arousal. They come out of it quick. That's a wonderful thing. Traumatic comas, better prognosis than a coma that's caused by structural lesions or damages. And traumatic coma is better outcome than a non-traumatic one. And that kind of sometimes might make sense. We don't know. We haven't figured it out yet. Like I said, we might give Narcan, narcotic antagonist to try to wake them up. Thiamine, we might, because of how some alcoholics and what have you may have some deficiency, and we may give them some glucose, to try to take care of some of the things that could be happening. So when we're looking at clients that are totally in a coma, they are totally dependent on us. So we are their advocates, which we are all patients, but for sure we are on a patient that's in a coma that has no wakefulness, no awareness. So our interventions are directed toward taking care of their activities of daily living, everything for them, supporting their body functions, doing surveillance for any other complications, and providing comfort and what have you for them and their families. Now, the difference in a coma and a persistent vegetative state is that these patients, however this happens, they have periods of wakefulness, but they are not aware. So that's the difference. They are in a state of unconsciousness, but they have periods of awake cycles. That's totally all it is. It's not that they're clued in. They're not following you with their eyes. None of that. Complete unaware of themselves, surroundings, anything. And there's a whole list of criteria that they have to have applied to them before they can be called a persistent vegetative state. And I listed just a few things here, but they're kind of what we just said in the definition, actually. So there's no treatment to reverse it. Nothing has worked. Their average life expectancy is like 2 to 5 years, and that's because they're going to be on tube feedings and be in a nursing home or taken care of at home or what have you. But it's like they're in a locked-in state and unable to communicate and everything. That's really a terrible thing. So that's got to be made by a specialist, so we just don't willy-nilly go and say, well, they're in a persistent vegetative state. That it's really a terrible thing to have done for patients or their families. Okay. And that brings up a lot of moral and ethical issues, as you can imagine. Do we tube feed? Do we not? Do we give medicines? What do we do? And it's hard to stop things once you have them started. So that's one of those reasons it's very good to have a durable power of attorney for medical or health care, so that your wishes can be known, and that is a stretch of the imagination.